Hi, today we have Dr. Peshala Gamage from Florida Institute of Technology talking about seismocardiography, genesis and utilization of machine learning for variability reduction and improved cardiac health monitoring. Dr. Gamage is a visiting professor in the Department of Biomedical and Chemical Engineering and Sciences at Florida Tech. He worked as a postdoc researcher in the same institution before his current role. Dr. Gamage received his PhD in mechanical engineering and his master's degree in aerospace engineering, both from the University of Central Florida in Orlando.
Thanks for everyone participating in the seminar. And I'm Peshala, and I work as Amir said right now, visiting assistant professor in Florida Tech. And the research I'm presenting today, most of the work I did it in UCF, University of Central Florida in Orlando, and some of the work I already also work with Amir also. And I think because you guys are working with Amir, maybe you guys are already familiar with seismocardiography, what that means, right? But today in my talk, what I'm going to cover, how this signal, seismocardiography, is generated in the body, right? And then what are the issues with this signal? Why this signal is not very popular? Why it's not like frequently used in cardiac health monitoring? And also what are those issues and how to like fix those issues, and how to make the signal, the utility of the signal, how to increase the utility of the signal, and how to use it in cardiac health monitoring. So this is my outline. So I'll start with the motivation of our research, and then a brief introduction of seismocardiography and the research focus. So here I will discuss about these three areas: the genesis of SCG, reducing the variability, morphological variability of SCG, and also using SCG to predict heart failure patient readmission. So the motivation is, as you know, always cardiac related diseases are the number one cause of death worldwide, right? And one reason for this is most of these deaths are sudden death because the medical attention is not received at the correct point. Always it's mostly at the later stage the symptoms are shown, right? Because of that, this is the main reason why these cardiac related diseases are deaths are so much, right? And also if we think about patients who already have heart failure patients, after they are discharged from the hospital, considerable percentage of them, they get readmitted again, right? So according to some research, it says 20% of the admitted heart patients, they are readmitted within 1 month, or even up to 50% within 6 months. So this percentage is very high, right? And also why we talk about seismocardiography? So we believe that it is a non-invasive way of measuring cardiac activity. And also if you think about the cost, we just need an accelerometer to do it. So the cost is lower compared to most other methods. And also we believe that it gives very important information about the heart, right? So if we can use SCG, improve the utility of SCG in health monitoring, cardiac health monitoring, it can reduce the deaths, improve the quality of life, as well as reduce the associated cost, right? And seismocardiography, as you can see in this figure, so here this one is a accelerometer attached on the chest surface, close to the heart. And these three are just ECG electrodes, right? So basically the ECG electrodes, what they will measure the electrical activity of the heart, right? But this accelerometer, what will measure, it will measure the vibration of the chest surface, right? But since we especially attach it close to the heart, we believe that this vibration is mainly coming from the heart vibration underneath the chest, right? So the signal we get from this acceleration, we call it seismocardiography, right? And also there's different terms used for seismocardiography. Sometimes some people use it like vibrocardiography also, But the term seismocardiography, it comes from, I think, especially because of the frequency range that we consider in this signal. So usually we consider, in our research, we consider frequencies from 0.5 hertz to 50 hertz. But some people, they consider from 5 hertz to 50 hertz, so it can change, right? But in this frequency range, we have two regions, right? We have subaudible region and an audible region. So frequencies below 20 is subaudible. If the frequency is higher than 20, it's also audible, right? So it consists of both these frequency like ranges, right? And also that's the reason it is called seismic, like it's like seismic waves, right? Seismocardiography. And as I told you, why the use of SEG is limited. So the reason, the one reason for this is there's not enough knowledge or enough studies, because compared to, so this signal which we show here is the ECG signal, which is very known and well established, right? And all these peaks we can relate to, like which what's the time of the heart like contraction, and what they do, we know exactly where it generates, so we know about the genesis of this signal, right? But this is the ECG signal. So first you can see it's like, compared to this signal, it has so many fluctuations, first thing, right? And also when it has so many fluctuations, so it can have like so many different feature points, right? So it's hard to say. So in this figure, I put these annotations like AS, AO, all these things based on previous research, but still these we call these fiducial points, these are also debatable. So because in some subjects, healthy subject, even in healthy subject, we may see these features, or in some case we may not. So these are not very well established. And then also the genesis of this signal, we can say it's not very well established, right? And also you can see the variability is still high, right? And also when we talk about variability, another reason, so we measure something on the chest surface, right? And when we measure something on the chest surface, so the chest vibration can be affected by the respiratory variation. When we breathe, the chest moves, right? And also when we breathe, the position of the heart can also move, and also the pressures around the heart can move, right? So this pulmonary or the respiratory activity can also change the signal. And apart from that, there can be some other movements if the patient moves while acquiring the data, and also some bowel sounds. All these things can come into account, but we can actually if we use correct procedure, we can limit those, but still we cannot remove the variation comes from the respiratory activity, right? Because the signal is not very well understood, and also the respiratory variation, it's hard to extract good, nice features from this signal, right? So that's one reason this is the utility is limited in this SEG signal. So our research focus, so first we wanted to study how the signal is generated. In this case, the main idea was to study how the propagation of especially the ventricles come to the chest surface, right? Because later in the third stage, we wanted to use this signal to predict heart failure readmission of a reduced ejection fraction patients. So we believe reduced ejection fraction, later I'll explain. So this is mainly associated with the way that heart can contract and push the blood away to the body, right? And if the movement of the ventricles is directly related to SEG, then we can say that there are direct features, direct association with the movement of the ventricles and the SEG. So that's one, like, I think the main reason we did the first part of our project, right? Understand the genesis of SEG, where we use, I'll show you later. Basically, we modeled how the heart wall movement propagate to the chest surface, right? And then the second one, we want to reduce the morphological variability. So we use some machine learning, unsupervised machine learning techniques to separate SEG beats into different groups. So they will reduce the variability, and also we analyze how this separation happens in relation to the respiration. And in the third part, with better understanding of the genesis, as well as understanding of how to reduce the morphological variability, we try to derive good features so we can predict heart failure readmission. So moving on to the first research focus, understand the genesis of SEG. So the methodology we employed, so we wanted to simulate how the heart wall movement propagate to the chest surface. So first we needed to capture how the heart moves, right? To do that, what we did, we use medical imaging, and here we use 3D short axis cine MRI imaging. So the cine term comes from, it's like a movie. So we can also call these type of images like 4D MRI images, which can capture the movement of the heart in 3D and also in time, right? Then using this imaging, we use some motion tracking algorithms to capture the heart wall movement, right? And then we took that movement and then we imposed that movement as boundary conditions in a finite element model. And that finite element model, it helped us to analyze or visualize, understand how the propagation goes to the chest surface. So these are an example of short axis MRI imaging. So especially in this figure here, figure C, it shows different sections of short axis imaging. So each of these image, we call them short axis imaging. And the first one is a different view. We call this two chamber view, and this one we call it a four chamber view, because in this view we can see all four chambers, and this one we can see two chambers, right? So usually a cine MRI imaging, it comes from with one two chamber view, one four chamber view, and several short axis view. And if we combine this short axis view, basically we will get a volume which looks like this, right? So this is basically a chunk or a segment of the chest. And if we locate this volume, 3D volume in your body, it will be in a region which looks like this, right? And also these small dash lines here, it shows the different sections that these images are taken, right? And then these figures here, we can see the walls of the left ventricle and the right ventricle easily, right? And then next step was to capture how the heart wall moves. To do that, since we have our images, we call it 4D images, right, in time, and also at each time step we have volumes, right? So what we did, we use a motion tracking algorithm, a concept called optical flow, basically how the intensity level changes. From that we can capture how the location of each pixel with like similar intensity moves in another frame, right? I won't go into details about the method, but we basically use a method based on 3D optical flow, right? And here you can see this is just a figure showing like 3D vectors on the heart wall. When I say heart wall, so these points are located in the pericardial fat. So it's like a layer around the heart. And then we have these images, short axis images. From that, we reconstructed the 3D geometry of the chest, right? So here we only reconstructed just a part of the chest that we need. So we don't need to model everything, right? We just need to model certain part of the chest so we can analyze what happens to the how the SEG looks like, right? So here you can see we already included the chest muscle, and from the image we could get the location of the sternum, so we included that. But from these images, the contrast level is not good enough to find the ribs and intercostal muscles, all these things. So these things we just included into our model separately, right? But we included the muscle, chest muscle, and the sternum and the ribs, and even in the ribs we separate the region which is more flexible, made of cartilage. And also we have a part of a lung, right, which is in the chest in our model. So we try to make it like as realistic as possible, while also keeping it simple, right? And then this is showing the our model, finite element model. So we basically meshed it. And then this is the inner surface, which means this is the boundary of the heart that we consider. So from the medical imaging, we captured how these points on this surface moves in time. And we captured that, and then we imposed it in our model. So these small dots is just a representation where the where this movement is mapped, right? And then MRI images are acquired during breath hold. Breath hold means you don't breathe, right? And during breath hold, the ribs, they don't move. Because of that, in our model, the other boundary conditions were we considered the like the boundary surfaces of the ribs, we considered them to be fixed because images are acquired during breath hold, right? And then our model is fixed at the rib cage, right? Edges of the rib cage, and we have input movement which we got from the images, right? And then we could simulate how the chest acceleration looks like. So this figure, it shows here how our model geometry like looks like, and also these values, it's just showing the variation of the acceleration in this case, right? And then here we compared 4 points, 1 point on the sternum, 1 point on the xiphoid, and 1 point in the fourth intercostal space, and another one in the fifth intercostal space. And we just recorded in our simulation how this signal looks like. So these are the results, how the simulation looks like. And you can see, we can see these regions, fluctuating regions, which is similar to actual SEG measurements. We call the first region, we call it SEG1, which is similar to heart sound 1. And the other fluctuating region, we call it SEG2, which is similar to heart sound 2, which is related to a valve movement, right? And also, in our simulator signal, we could also identify certain feature points, which is comparable to the literature, right? So also we could identify from our simulated model these feature points also, right? And also we could validate them based on the time that these feature points occur. We could validate these are the actual feature points, which means in this case we have made a simulation, and our simulation, it looks like the SAG signal, like measured SAG signal, and it also shows some feature points. So this kind of validated our model, and also we say that we could accurately kind of simulate how SAG looks like, right? And using our model, we analyze more things. So this is another view of the model. So this is actually how the heart wall moves, right? And then we could, because this is a model now, we can do so many things to this. So one thing we did, we changed the stiffness of this heart muscle, right? And analyze how that affects the SCG signal. So what we found, basically, when we increase the stiffness, the amplitude of the SCG measured on the chest will increase, right? So, and another major thing that this simulation tells us, so what we input to the model is the movement of the ventricles, right? Ventricle walls, right? So when we input the movement of the ventricle wall on the chest surface, we got a signal which looks very much like the SCG signal. So we can say that the SCG signal we measure, it is kind of ventricular movement is a dominant source of the SCG signal that we measure. It's like directly related, right? And also using our model and some experimental measurements, we did more things. So this is the experiment we did using 36 accelerometers. So we made an array on the chest and we measured SCG at the same time, right? And then we recorded the spatial variation of the signal magnitude, right? So here you can see how the signal magnitude looks like at each different location at time points at these annotated points. So basically these are feature points, right? And also this is our simulation, and our simulation and the experimental results, they showed similar trends, and also this further validated our model. We can say this is kind of a comparing with some experiments and validating compared to the experiments, right? And also using these we decided which is the best place to place the sensor. So based on the amplitude of different features, and also in our experiment, we also plotted, I'm not showing that here, but we also plotted the signals to noise ratio and all those things. And we decided, we found a best place to place the sensor also. So that place was actually around fourth intercostal space near the sternal border, and that range we did it in experimental measurement in 13 subjects. According to that region was like 3 centimeter wide, and it's around fourth intercostal spaces just near the left sternal border. And the other conclusion from our study, as I already mentioned, so dominant effect of ventricular wall movement is shown on SCG, right? And then a higher chest tissue stiffness mean higher SCG amplitude, right? And also we did more things. So because this is a model, right? So in our model, if we want to measure acceleration, let's say on the chest surface, on the rib cage, and on the wall, we can measure anywhere, right? But we cannot do it experimentally. So what we did, if we select a point on the chest surface, we selected a relative point on the heart wall, and we measured the acceleration on the heart wall. So what we saw, the signal was also like similar to SCG, but with much higher amplitude, and the peak points, they had much higher amplitudes, right? So basically the same frequency kind of propagated to the chest, but the amplitude is in some places significantly reduced and some places not. And I'm not showing that here, but we looked into that too. So the next part of the project is for, I told you, one problem is the high variability of the SCG signal, right? So then our focus was to how to reduce this variability, and also how to understand how this variability relates to the respiratory variation. So again, here what I show is like an ECG signal and the corresponding SCG signal. You can see the SCG signal has very high variation, right? And we believe, so especially if we think about this respiratory variation, or we call it variations due to cardio-pulmonary interactions, we have some hypotheses, right? One is this signal variation is mainly happens because of the heart position. So during breathing, the position of the heart also changes. So if the position of the heart changes, the relative position of the heart and the sensor also changes, right? When that happens, the signal should change, right? And also another one is the interthoracic pressure. So during breathing, right, when the interthoracic pressure goes low, which means the pressure around the heart becomes lower, right? And vice versa during expiration, right? So because of that also, it can affect how the heart moves, right? And also amount of blood comes into the, especially right heart, it changes during inspiration because of this interthoracic pressure, right? Because of that also, it can change the movement of the heart, the way the heart moves, and it can be reflected in the corresponding SAG signal, right? So these kind of hypotheses are there, and because of that, previous research, basically, they consider that SAG events can be separated based on these hypotheses as inspiration and expiration. So beats, SCG beats, SCG heart cycles during inspiration looks in a certain way and expiration look in another way, right? And some other research, they also mention, so this is not basically just based on inspiration. This is more related to the lung volume, how the lung volume changes during inspiration and expiration, right? So there are different studies have reported different things, but still uh, uh, there's no explanation how exactly this respiratory this effect or the respiratory variation affect the SCG, and what's the relation to the respiratory phases, right? So with the methodology we employ to do this is this way. So first we acquire the data, and when we acquire data, we acquire the SCG, and also at the same time we acquire the ECG signal, and also we acquired the respiratory flow rate. So we acquired three signals simultaneously, right? And then we process the data. So process all the data, remove the noise, right? And then we also segment SCG beats using ECG. So when I say SCG beat, I'm talking about one SCG signal acquired during one heart cycle, right? And then we use a unsupervised clustering algorithm, and basically we ask the machine learning algorithm to separate the SAG beats into different groups such that they have minimum variability, which means separate them into two groups so they have similar events in each group, right? And then we analyze how these clusters or groups occurs in relation to the respiratory phase. So this was our experimental setup. So here you can see we have a spirometer to measure the respiration, and ECG electrodes, and a accelerometer, right? And we did measurements on 17 healthy subjects, right? And our results are based on that. So this is what I talk when I say segmenting SAG. So this is what I did. So basically this is our SAG signal and this is the corresponding EKG signal. So the segmenting, we did it in this way. First we identify the R peak of the EKG signal and then started the corresponding SAG signal 0.1 second before the R peak and ended it 0.1 second before the next R peak. So this, from here to here, this will be one SAG beat, and this is another beat, and this is another beat, right? So that's how the segmentation happened. And this figure here, it shows, I can say, stacked SAG signal on top of each other, right, from a single measurement, right? And if I zoom in, here you can see different SAG beats, and these SAG beats are, I can say, adjacent SAG beats, right? But even here, if you look carefully, you can see there are some differences between consecutive SAG beats. There are some morphological differences, right? So which means there's a beat to beat variation of the SAG signal. We can even clearly see it if we just plot it like this. To our eye, we can kind of recognize there are some morphological differences even between some consecutive beats. So we wanted to analyze how this happens, right? So the method we employed, uh, the unsupervised clustering method we employed is called k-medoid clustering. Maybe you guys are familiar with it. Uh, and also with k-medoid clustering, we use another measure which is called dynamic time warping dissimilarity. Basically, the short name is DTW. DTW is basically a measure. So I'll briefly explain what DTW is later. But if we look into k-medoid clustering, so this schematic or figure here, it explains how this clustering algorithm works. Let's say these diamonds, these are our SCG beats, right? So when the clustering algorithm starts, first it will just select two medoids, right? So medoid is kind of similar to centroid. So medoid is a representative of a cluster, right? So it will just initiate two medoids and then assign all other it will calculate the distance to all other SCG beats, and then if uh, one SCG beat is closer to a certain medoid, it will assign that SCG beat to that medoid. In this case, you can see in this step, these two beats are assigned to this medoid and these beats are assigned to this medoid, right? So now it has separated into two clusters. And then again, after doing that, it will again calculate the medoid of each cluster and again follow the same process, right? And it will do that until the cluster assignment doesn't change anymore, right? So in this case, it will do this. So the new medoid, which is kind of the centroid, will be here, and then it will find the cluster associations, and then it will look like this, right? And if we do this again, this will not change actually in this case. So our final result will look like this. So the beats will be separated into two groups, right? So now the question is how we measure the difference between the medoid and a SAG beat, which means how can we measure the difference between two SAG beats, right? So one way to do it is using this Euclidean distance, right? So you all know how to calculate Euclidean distance. So if you know 2 points, you know how to get the Euclidean distance. And here signal is made of several points, right? And if we want to get Euclidean distance, we need to consider each corresponding point and get the difference, right? And if the distance or the time of each beat are different, we have to truncate certain amount, right? When we calculate the Euclidean distance, because the number of points between two beats should be the same. But in dynamic time warping method, what it consider is the dissimilarity based on the morphology. So it kind of warps the signal into the other signal and then get a measure, and that measure is an indication of the SCG morphology, right? And then there's a certain way that this algorithm works, but I won't go into details. But interesting thing about DTW, it is kind of invented for speech recognition, which means in speech recognition, let's say if I say the same word quickly and slowly, if you check the signal, of that word, if you record it and check the signal, the morphology will look the same, but it may be stretched or compressed, right, based on the speed I speak, right? So, but using this DTW measure, it can get it can basically find whether the morphologies are similar or not. So we basically employed the same technique, the discriminant technique, in our clustering. So that's something like we added to this machine learning model, right? And then in clustering, the first question is how many clusters should we use, right? Which means what's the optimum number of clusters? We can divide SAG bits into 2 groups, 3 groups, 4 groups, like that, right? So one way to do it is using this elbow method, right? So basically, elbow method, it's done by plotting the cluster variability, intercluster variability, against the number of clusters. So when you do that, you can find the elbow where there's the maximum angle, right, when this happens. So that elbow occurs at the optimum number of clusters, right? And here SOD is a measure of the intercluster variability, basically getting the distances from each medoid to the ECG beats that inside that cluster, and then add all of them and divide by the total number of ECG beats, right? So this method can be used to find the optimal number of clusters. In our case, we used several methods, including elbow method, and in all cases, we got the optimum number of clusters to be 2. In another way, if I say this, if I separate SAG beats into more clusters, it won't reduce the variability that much, right? If we go from 2 clusters to 3 clusters, the change in variability will not be that much. So there's no point of doing it, right? And then so we found that optimal number of clusters are 2, and we asked the algorithm to divide the SAG bits into 2 clusters, right? And then we wanted to analyze how this cluster division of this cluster, how it relates to the respiratory variations, right? So you remember we got all measurements, SCG, ECG, and the spirometry measurements at the same time. Because of that, we could plot this signal, the flow rate, right? And on flow rate, we could plot the occurrences of each HCG beats. Occurrences mean when does this certain SAG beat happens, right? Although SAG beats is like the time is like a heart cycle, here we considered just the time of the R peak of that SAG signal, right? So if the R peak of that SAG signal, corresponding R peak of that SAG signal happens in a certain time, we use that time to plot that SAG signal on the flow rate signal. So the first plot, it shows the flow rate signal, and on top of that, it shows the timing of each SAG beat, and these different colors are for different clusters. So let's say blue color is for cluster 1 and red color is for cluster 2. And the second plot here, it shows the variation of lung volume signal, and then the timing of the SAG beats, right? So if we just check these 2 plots, right, clearly we cannot see how to separate, right? We cannot clearly say that the clusters, they separate based on flow rate, right? Because if you think like, let's say flow rate is negative, when the flow rate is negative, in that region we have both red and blue markers, right? Which means beats happen, like beats of like the 2 clusters, they happen in inspiration and expiration. So inspiration, expiration is not a good way to just divide these SAG beats. And same goes to lung volume, right? So it doesn't matter lung volume is positive or negative. In both positive region and negative region, we have red and blue markers. But compared to flow rate, we can see in lung volume, most of the blue markers are on the positive, right? Which means if someone use lung volume to separate SAG beats, it's actually better than using the respiratory flow, I mean just the breathing, right? And another like a new thing we did, we thought, why not we analyze both of these together, both flow rate and lung volume. So we had to make a 3D plot. On x-axis we have flow rate, and y-axis we have lung volume, and if we combine these plots in 3D, it will look like some circles or swirl like this, right? And then the distribution of the clusters, these points in 3D, it looks like this, right? Then we thought if we project this 3D plot, especially the distribution of these clusters into like a 2D plane, what we got is something look like this figure here, right? So in this figure, you can see clearly there's a separation between cluster, let's say blue is cluster 1 and cluster 2, right? So now when we want to analyze this, what we did, we separated the respiratory phase respiration into 4 phases, right? So according to this, during inspiration we have high lung volume, and also during expiration we have high lung volume, and then during, you can say, expiration, the lung volume should reduce, and again inspiration, lung volume should increase, right? But we can divide the respiratory phases into 4 different groups like this, right? In that case, according to this study, so we did it in 17 subjects, and in all 17 we observed the same pattern, which means this pattern is consistent, right? And here what we saw, the cluster change or cluster switching, it happens in these phases: low lung volume during low lung volume inspiration, and during high lung volume expiration. So this is the phase where this transition happens. And also we kind of call it the cluster change happen in like early inspiration and also early expiration, not exactly during inspiration or expiration, neither high lung volume, low lung volume. It happens at a certain stage, right? Like a transitioning stage like this. And also these figures, these shows the ECG beats for one patient or one subject, and how the ECG beats of 2 clusters look like. So if generally you can see cluster 1 and cluster 2, they have 2 different morphologies, right? But within those morphologies, also inside each cluster there are variations, right? So there are variations inside the clusters, right? So next we want to analyze the variability within clusters, right? So we already know there's a morphology difference between cluster 1 and cluster 2, but within each cluster also we have some variations, right? We thought that these will serve as good features later when we want to use it for monitoring cardiac health. We thought that we will get like some more information about the heart and the respiratory effect of the heart if we analyze this further, right? Okay, and this figure here, it's a little bit complicated when you just see it, but let me explain. So let's start from these figures. So this figure here, it shows the 10% of events closest to the medoid one. So this means these uh, beats are from, let's say, cluster 1, and these beats are the closest beats to the medoid of cluster 1. So in K-medoid clustering, I described what is the medoid. So medoid is basically the representative of the cluster, and these beats are the beats which are closest to the medoid, which means they should look similar to the medoid, right? And similarly, these beats are the beats closest to the medoid 2 in cluster 2. So these are the ECG beats closest to the medoid of cluster 2, and then they all have kind of similar shape, right? And these are the beats which are furthest, like away from cluster 2. So 10% of the events furthest from cluster 1 medoid 1, right? And you can see in that case, even between these beats there are some variation, right? So same goes to cluster 2. So which means if we analyze the inter-cluster variability, right? So the medoids which are closest, so events which are closest to medoids, right? They have the least variation, right? They have less variation, which means they look similar to each other. And then when we go further away from the medoid, so those the variability increase, and also they don't look similar, right? And also we could explain it using this plot here. So this plot is nothing but it plotted the distance between each beat to the medoid. So medoid is at 0, right? And this first one is the closest beat to the medoid, and then this axis is the each ECG beats in increasing distance from the midpoint, and same for the cluster 2, right? So if we just select some beats close to the midpoint, then they will look similar, and also the heart rate is kind of close to each other, as you can see, right? But when we go away, the variability increases. So what does this tells us? So this tell if we want to get some features from SCG, right? Especially, let's say after separating into clusters, it's better to get the features from the beats which are closest to the midpoint, because they look similar to each other and they are kind of like an accurate representation of each cluster, right? And if we go further away, so then the morphology also kind of dissimilar, and the heart rate is also dissimilar, and it won't when we want to find a representative to each cluster. So if we get a beat around here from the away from the midpoint, then it won't serve as a good representative of that cluster, right? So especially this is important later when we acquire features from SAG signal. What we did, we separated the SAG bits into clusters, and then we identify the SAG bits closest to the midpoint, and from that we got average signal to get the features, right? So the main conclusion from this reducing the variability of SAG signal. So one, we found SAG waveforms are optimally clustered into two groups, right? And the switching from one cluster to other cluster consistently happens during first half of the inspiration and the expiration. And also, if we use this kind of clustering, we saw that it can reduce the original variability of the SAG beats by around 15%. All right, so let's go into the third research focus, which is the most important one. So this is for predicting heart failure patient readmission using the SCG signal. So now before that, we already kind of understood through our research, we understood that ventricular movement is directly related to the SCG waveform, the SCG morphology, and also there are respiratory variations, right, happen certain way, and how the, even when we separate into two clusters, how the intercluster variability changes. So we, with all this idea, we moved into this project, the third part. So here the main focus was to predict heart failure readmission of reduced ejection fraction patients, right? Reduced ejection fraction means the heart cannot pump enough blood out of the heart, right? So the ejection fraction of blood is limited, right? And usually this happens because the myocardial wall or the ventricle wall get weaker, right? When it's weak, it cannot push enough blood outside the heart, right? And if we believe that if this is associated with the pumping of the heart, we believe that this is also directly associated with the SCG signal that we measure, and because of that, SCG signal is a good way to find features of these type of patients, right? And the main objective here is to identify which patients will be readmitted after the initial discharge. If we can predict which patients is like to be readmitted, then the doctors can pay more attention to those patients. So there can be like immediate pre-interventions, right? And it can help increase their life quality as well as reduce the costs associated, and also save their lives, right? So in this study, at the time we did this study, as I remember, we already acquired data from 41 heart failure patients, right? And the way we acquired the data is it's a longitudinal study, which means we acquire data in time. And so these patients, when they were like initially discharged, we get their recording, and then we plan to get their recording again after 2 weeks, and after 1 month, and after 2 months, and after 3 months, and after 6 months, like this. So it was a longitudinal recording, right? So at the end, in our analysis, we have 25 recordings from readmitted patients, and then 26 6 recordings from non-readmitted patients. So later I'll explain how these become 25 and 26. Okay. And also in our recording, there were some patients with pacemakers, which are with actively paced pacemakers, and we excluded them from our study. Right. So the methodology we employed, so we acquire the ECG data, longitudinal ECG data, and then we process this signal, ECG signal, and then we acquire different features, right? Here we did our study, we analyzed different features, and then we sorted different features such that these features, whether they can effectively distinguish or discern between these readmitted and unreadmitted groups. After sorting the features, we can use some machine learning algorithm to predict the readmission. Okay, so this figure here, so basically this one is very important to understand. Basically this figure here, it shows the collection of data points, right? So each of these line, I'll say each of these line, they represent a patient. So these numbers are the numbers that we gave for different patients, right? Patient numbers. And each of these points, they represent the time of data collection, right? So which means if you think about patient 24, we collected data at a certain point, let's say at the discharge, and then around maybe 10 days from the discharge, and then after maybe close to 40 days from discharge, right? And here, the reason for having two plots is because we wanted to separate the non-readmitted heart failure patients and the readmitted heart failure patients. So for non-readmitted heart failure patients, we calculate the date starting from the initial discharge, day of initial discharge, which is 0, right? So it means 0, and then it goes in this direction, right? This is after the discharge, right? And for readmitted heart failure patients, we calculate the dates from the readmission, the day of readmission. So 0 is the day of readmission, right? And then all the days are negative, so these days are before the readmission, right? So the reason we separated these two groups like this, because we wanted to have data in two groups, so we can sort features or find features to classify non-readmitted and readmitted groups. So in this case, if you think about this, so all the data points which is inside this blue region, so all those data points are data that patients are not readmitted after 60 days, right? So let's say if you take a measurement here, right? So after 60 days of these measurements taken, these patients are not readmitted, right? So also, although you see that this 10 patient number 10 ends here, right? Even though we don't have their like data recordings, we know that this patient is not readmitted again, right? So within 60 days after this, they are not readmitted. So all these data points are data points where the patient is not readmitted, especially after 60 days, right? And all the data points here, right, are the data points where the patient is readmitted, right? When it goes to 0, patient readmitted, right? Readmitted within 60 days, right? So like that, we could make two groups from our recordings where the patient is not readmitted and patient is definitely readmitted, right? So data in these two groups are the groups that we use to analyze our features and sort our features, right? So other than that, now we have a group for non-readmitted, which is shown in blue color, readmitted red color, and on top of that, we also use some data from healthy subjects, right? Data from healthy subjects, and we analyze the same features just to see how this distribution of healthy subjects compare to these two groups, right? So ideally, the healthy subjects should be more closer to non-readmitted group. If our features are good, they should be close to the non-readmitted group, right? Because the readmitted group, it's an indication of the heart condition getting worsened, right? And non-readmitted means heart condition doesn't get worse that much. That's why they are not readmitted. And overall, in our analysis, we analyze 103 total features. So out of these 103, 3 of them were SCG morphological variability features. So these morphological variability features we got from clustering. So one can be inter-cluster variability like that, right? And then 92 features were formed by getting the average and the difference of 46 SCG features between the two clusters. So let's say we have a certain feature, right? And we know after clustering we have like 2 clusters. So we can calculate the average of this feature in 2 clusters, and also we got the difference of this feature within 2 clusters. In that way, we got 92 features out of 46 features, right? And also we analyze 9 most commonly used heart rate variability features. These features are just derived based on ECG. So for getting these features, we don't need SCG. So we just use ECG because these are some commonly used features. And when we talk about features, these features, they fall into so many different categories. So one is, can be the variability or time amplitude features or frequency features, spectral features, right? And then time frequency features, spectrotemporal features, and also instant frequency features. So there are so many different, you can put them into so many different categories, right? And this one I won't go into detail. So this is just some examples of how we calculate these variability features and spectrotemporal features. So variability features, it comes from clustering, right? Basically calculating the sum of distances from each medoid to different beats, right? And then spectrotemporal features. So we use time frequency distributions based on polynomial chaplet transformation, right? And then from these we also found different type of features. So in this figure especially, you can see there's like a certain high frequency region here, and another one here. So this is we call SCG1 related to first heart sound, SCG2 related to second heart sound. Then also in patients we may have SCG3, which is related to third heart sound, right? Like that, based on these different frequencies and how they varies, we came up with different type of SCG features. So one example is SCG1 amplitude audible, right? So this means amplitude of SCG1, right? But that amplitude is only taken for the audible rate, which is from 20 hertz to 50 hertz, which means around this region, and the amplitude in this region, right? Like that, we derived so many different type of features, right? And also instantaneous frequency features. So this signal here, it shows how the instantaneous frequency of a SCG signal varies, right? And from that also we could get different type of features from this signal. And this one, it shows the commonly used heart rate variability features. You can find this in many literature, right? So basically these features, they describe how the heart rate variability changes for in different frequency ranges, how this changes, and these are just calculated based on ECG. And we have like 103 total number of features, and from that we sorted mainly 14 features, right? And in this table I'm just showing you the 14 features and their descriptions. I won't go into each of them, but these are the results. And then this shows the p-values between the readmitted and non-readmitted group, readmitted and healthy group, and non-readmitted and healthy group, and both readmitted and non-readmitted with the healthy group, right? So if we want to visualize the variation of these features graphically, one way to do it is using a principal component analysis, or PCA, right? So when we have many variables, if we want to see how these variables separates our groups, we can use PCA to do it, and it will find some component axis which maximally separate our features, right? So when we did that, so this is a representation of the PC analysis for these 14 features. And as you can see these red dots and the blue dots, they are kind of separated using these features, right? And also you can see the green dots, they are in the side of the blue dots, right? which means the healthy data points and the non-readmitted data points, they fall into one side, right? Which is what we expected, right? Because non-readmitted group, it should be close to the healthy side, right? And it also serves as some kind of validation for our features, right? Okay. And then since we have these 14 features, we use this method called linear discriminant analysis. So this is a way that we can combine multiple features and derive one feature from multiple features, and this one feature will be able to maximally separate two groups, right? So I won't go into detail of LDA, but you can use basically LDA to derive a new feature from multiple features. So in these plots here, what I'm showing is the different features, the P distribution of different features between the readmitted and non-readmitted group. And the final one here, it shows the final feature using the linear discriminant analysis, which means if you combine all these features in a certain way to have the maximum separability between two groups, and you can create a new feature. So that feature looks like this. You can see it kind of separates the whole thing. Is separated, right? And if I plot it, it basically it separated the groups 100%. It separated the two groups, the LDA derived feature, based on these 14 different features. And also now, since we have sorted the features and also we kind of derived one feature using LDA, we use those to with machine learning algorithms to find the accuracy. So here what I'm showing is the results for leave one out accuracy. So here when I say leave one out, this is just leaving one recording or one SEG measurement session out, and use all the other SEG measurements to train the classification model and test it on the left out SEG recording. And in that case, we could reach using our features, we could reach when we use support vector machine, it's a way of machine learning classification. When you use support vector machine, we could reach 92.16 accuracy. And when we use this method, we call it K nearest neighbor method. And when we use it with just the LDA feature, the combined feature, we could reach to accuracy of 98%. And this one here, it shows a graphical representation of the support vector machine SVM algorithm. Basically, what SVM does, it kind of, we call it a hyperplane. It finds a hyperplane to divide the two classes, right? So in this case, because we wanted to show it in 3D, we just did this SVM algorithm with three features, so we can graphically represent it, right? With three features. If we use, like we had 14 features, if I use 14 features, there's no way I can graphically represent it. That's why here I'm just showing a SVM algorithm with three features and the separation plane. Okay, so this figure here is one, I think the most important, the way of showing the predictions. So we call it leave one patient out prediction, which means from the recordings, in this case, we take out the whole recordings from a certain patient. Let's say if I want to make the prediction for patient number 24, what I'll do, I'll take all these three data points, I'll keep it away, and I'll train my algorithm, the machine learning algorithm, using the data of all other patients, right? And then I'll use the data for 24 as the testing data, right? So in this case, these figures, basically they show the predictions. So if any point is shown from blue color, it means the prediction is that this data point will not be readmitted within 60 days, or let's say they are not, they will not be readmitted. If a data point is shown from as red color, it means that data point, the patient with that data point will be readmitted within 60 days, right? So as you can see, so these are the prediction for all the patients like that. And you can see the only misclassification we can say occurred here for patient 8. And then in this case, for patient 31, we have one misclassified point here, right? Because blue means he will not be readmitted, right? And then here also we have one misclassification, right? And this is when we use support vector machine with 14 sorted features, and when we use k nearest neighbor with that linear discriminant analysis derived feature, we combine all 14 features into one using this method. So here the only misclassification point was occurred here, right? So it means this one, it says like this patient will be readmitted. But if we go further, you can see the later data points of that patient shows like he will not be readmitted, which means maybe the condition got kind of little bit worse here, and then again he kind of recovered, right? So all this data, it's kind of a validation of what we did, and we believe because we carefully we analyze all the features, we analyze so many features, and we systematically approach our research, right? Starting from the genesis and then understanding how the cluster variation changes, right? And then we reduce the variability before acquiring features, and then we analyze multiple features between 3 different groups: readmitted, non-readmitted, even healthy group. Because of that, we believe we systematically sorted good features, and even we have like here we have like 25 data points in our training set and 26 data points in training set for readmitted and non-readmitted. We believe that this will prevail even we do this for higher number of patients. Of course, we need to verify this result with a more number of patients, but still these results they show like high utility of SCG in this predicting readmission, right? And then also what we did, another thing, so we thought like if we don't use SCG, if we just use some clinical scores, right? Like normally doctors use, can we use that to predict the readmission? So in this case, so this one I'm showing just one clinical score, which is called MAGIC, right? And the short name is MAGGIC, MAGIC. And basically this criteria, it gives a score, right? And if the score is high, so score range from 0 to 50, if the score is high, it means higher risk of the patient, which means higher risk mean we can say higher risk of readmission, right? But here we have calculated the values for the readmitted and non-readmitted patients, and if you see the range between two groups, so first this range goes from 0 to 40 and this one from 0 to 40, and kind of in the same range, right? Readmitted and non-readmitted groups. So which means if we just use this clinical scoring system, right, to separate readmitted and non-readmitted predictions, it means we cannot do it because this value range, they fall in the same range, right? And also we analyze another commonly used way, which is thoracic impedance. So this is a measure of the impedance to electrical current in your basically thorax. So this is measured similar, not the same way, but similar to ECG, using 2 electrodes and just measuring the resistance between these 2 electrodes, right? So if the water content in the body, especially in the lungs, is high, so we will have low impedance in the chest, right? So usually when the heart condition get worse, there's a high excess fluid built up in the body, right? In this case, the impedance go lower, right? But for all these are now heart patients, right? These are not healthy patients. Because of that, when we just use this thoracic impedance, we call it the SOE value also. The SOE value is not a good way to separate these two groups, because I think already these patients, they are heart failure patients, right? So also from these clinical measurements, we see that if we just use these clinical measurements, try to identify which patient is in high risk category, it's not a very good way to do it, because the value ranges, you can see it lies in the same range, right? But SCG, when we use SCG, it could actually separate the patients who are likely to be readmitted and non-readmitted. It could easily separate, right? So this shows like why we need SCG, especially in application like this. And the conclusion, as I discussed, so in this work, we claim that we found like 14 good features that can separate the readmitted and unreadmitted group. And then those features, they consist of the instant frequency features, and then waveform variability. So this waveform variability comes from clustering also, and then inter-cluster variability and intra-cluster variability. So variability within clusters, right? So those kind of features, they came into this base sorted 14 features, but we already analyzed some ECG based features, right? Heart rate variability features, but none of them, they they made it, they were sorted as the good features with like low p value. Also this kind of says that use of SEG is kind of needed in this type of cases, right? And the LDA derived linear discriminant analysis derived feature, single feature derived from these 14 features, it completely separated the training data, which is a very good thing. And then we achieved, like, using the data we have, we achieved accuracies up to prediction accuracies up to 92%, right? And then also we analyzed clinical scoring, which couldn't separate the readmitted and non-readmitted groups accurately. So this work is actually, it kind of, it validates the fact that SCG is a good way to analyze especially the heart failure patients, right? Especially in this application, heart failure readmission. And that's it that I have for today. And you guys can ask any question. I think it's a little bit late, but I think if you have time, you can ask more questions.
Thank you very much. Very nice work and great talk. Thank you very much for your time. Is there any questions? Do you have any questions for Dr. Gamage? If you have any questions, please unmute and ask your questions. So let me start with one question. So you said that basically for the healthy subjects in the second part of your talk, you said that the separation of clusters in the first mainly happened in the first half of inhalation, right? So in the third part of your talk, you studied heart failure subjects, and you mentioned that you also for some of the features you use clustering in order to find features in two different clusters. Did you happen to study if also that's the case for heart failure patients? For example, if the separation happens in the first half of inhalation, or it is different?
Yeah, so it can be studied, but the only thing is, like, in heart failure patient during measurements. So in this case, we use spirometry measurements, right? But in heart failure patients, we cannot use like the spirometry measurements, but still we can get the respiratory variation using the thoracic impedance. So we thought that the thoracic impedance signal, the variation, it's not actually the respiratory variation that we measure from a spirometer, right? Because of that, we didn't want to like compare it, but we can analyze it, but based on the change in thoracic impedance, because we don't have any way to extract the respiratory signal, right? Because heart failure patients, it's really hard to put a spirometer and ask them to breathe through the spirometer.
Right. Yeah.
That's the only like concern I had when I want to analyze that. But I think still, if we do that using the thoracic impedance, right, we can get some variation of the, like, especially the lung volume, right, using thoracic impedance. Then we may get some, I think we should be able to get some relation, but not exactly this, because we don't have the exact respiration. Yeah.
Okay. Thank you. Any other questions? And I have one more question, just it's a very minor question. So for the validation of your finite element modeling, you said that you developed an experiment with 36, I believe, sensors. So are these, I mean, did you measure these signals simultaneously? So it's a sensor array that you that are synchronized, all the signal outputs?
Yes. So
Okay.
we had a deck which can do that, and we also use like
And what? And do you remember what accelerometer? Do you remember
it's the same PCB accelerometer that we used for our research. So we had 36.
triaxial accelerometer?
Yes.
Okay. Okay, sounds good. Thank you so much. So if there are not any other questions, I would like to again thank Dr. Gamage for his time and the great discussion that we had, the great talk. Thank you very much. And please be in touch.
Okay.
Yes. Thank you very much.
All right.
Thank you.
Thank you. See you.
Thank you.
Have a good day.
See you.